Welcome back, everybody, to another episode of Explain This. I'm with the star of the show, Robin Riddle. Robin, I'm pumped to be here.
Absolutely.
We're going to have, this is going to be, I think it's going to be a challenging episode for me.
Yeah.
Because it seems to be very academic, and I think I'm going to learn a lot, though.
That's my whole point here.
And these are initials.
Yes, there's a
Kinda.
word. We talk about it in initials often.
Can I tell the people here what I think it's called?
Yes.
LP-A.
You are correct.
There we go.
Yes.
LP-A.
So today we are talking about lipoprotein A, which is most commonly referred to as LP-A.
Okay.
And you'll actually see the little a put in parentheses when you see this written somewhere. So this is a form of a low-density lipoprotein. So it's very similar to LDL.
Okay.
So whenever you do a cholesterol panel, you see your HDL and your LDL.
Okay.
LDL stands for low-density lipoprotein. So LP-A is a type of LDL.
Okay, so when we think of LDL, LP-A is a part of LDL.
It's a type. It's
a type.
very
Okay.
similar.
Okay,
Yeah,
got it.
Yeah. And so we typically think of LDL as like our not so good cholesterol. LP-A is also not so good in high amounts. So this is an established risk factor for atherosclerosis, coronary artery disease, stroke, thrombosis, and aortic stenosis.
Okay.
So all things that we don't want happening in our bodies.
Now, is this something that, we're checking often? Is that normal?
So LP-A, like I said, it's very similar to LDL, but it doesn't change a lot through life. So it's genetically linked or genetically determined. So it's not something that changes a whole lot. So it's not something that we're looking at super often.
Okay.
But the reason that it's a big problem is it's actually more sticky than regular LDL. So it can cause more issues in the body.
Okay.
So again, genetically linked. If you have a strong family history of elevated cholesterol, elevated LP-A, things like that, definitely a reason to be getting yours checked because that tends to run through the families.
So it's more something that's not going to necessarily get worse or improve a whole lot. It just is, and then there's stuff we do.
Pretty much.
Okay.
Now, there are some secondary causes that can make it worse. There's some things that can make it better. But studies show that your LP-A is set to like your adult levels by the time you're about 5 years old. So if you checked it at 5 years old and 25 years old, statistically, it doesn't change a whole lot.
That's super interesting.
Yeah, that's the genetic piece playing into
Now,
it.
I want to say it's on the Cleveland Heart Panel.
It is on the Cleveland Heart
Okay.
Panel. You're so good. This is something that we look at on our Cleveland because it is so important.
Okay.
So like I said, they're genetically linked. Also some secondary causes, some certain things that can elevate this more at times of life. So chronic kidney disease, nephrotic kidney disease, pregnancy can actually elevate this. Pregnancy is a time of stress in the body. And hypothyroidism, especially like not well-controlled hypothyroidism can elevate your LP-A. Menopause can also increase this, and at times of extreme inflammation can increase your LP-A.
That's super interesting. So there are times in your life where this could be impacted.
Yes.
And then I'm assuming that when this is impacted and you have an elevated LPA, it can cause these things to be worse.
Yeah, more potential for damage.
Okay.
So this is actually established as a risk factor for early heart issues in young people.
Okay.
So when you've got a 40-year-old that has a heart attack out of nowhere, if you check their LP-A, very often that's actually elevated.
Huh.
So it's estimated that about 1 in 5 people have an elevated LP-A. So
what?
Yeah, it's very, very, very common.
And you might have already mentioned this, and my just went right over my head. What is an elevated? Is there like a number, or is it just?
We haven't gotten there yet.
Okay.
I have not mentioned that yet.
Okay, cool.
That was actually my next thing. So
Okay.
levels below 30 are considered optimal. If you actually are looking at it on our Cleveland Heart Panel, optimal is less than 10 even on our Cleveland.
Okay.
So levels less than 30 are considered optimal for most labs. 50 and above are directly correlated to an increased risk for cardiovascular disease.
40 and above.
50.
50 and above.
Yeah. 30 to 50 is like that intermediate, but 50 and above is correlated with higher risks.
Okay. Now, if you're with a patient and you're saying, hey, you've got a LP little a above 50, like, do I need to be worried? Like, what's that?
There's
like?
some extra steps that we take from there, of course, and I'll get to the supplements and things. There's certain things that we can do to help it.
Okay.
But typically, I'm also referring out for a CT calcium score.
Okay,
at
so that
point.
goes along with this.
Which we've got a video about CT calcium score. We can link that down below. But definitely something that we want to look at this.
Yeah.
So, like I said, suggested that LP little a could be the reason that young people have heart attacks, cardiovascular disease, things like that. Increases our risks for all those. So heart attack, stroke, all the things, especially if we have family history. So familial hypercholesterolemia, like where you just have high cholesterol genetically.
Okay.
These are like your 30-year-olds with a cholesterol of 300.
Got it.
Yeah. That's a known risk factor. High LP little a on top of that, even bigger risk factor. If you have any of that in your family, it's really important to get yours checked. So like I said, it is more sticky than your regular LDL, so it can stick into the arteries a lot easier and create plaques or buildups on the wall of the arteries. That's where the CT calcium score can be beneficial, because if we see calcifications, we're more worried about plaques in those areas.
Okay. I'm with you.
So the higher your LP little a, the higher the risk for cardiovascular disease, heart attack, stroke, all the things.
Okay. So we definitely don't want this.
We don't want it, and we don't want it to be high.
And I'm also, I think I'm hearing it's mainly genetic.
Yes.
Okay. Because it's from the time we're 5, that's kind of where we are.
Yes.
But there's also things we can do.
There are things that we can do. So there are certain screening recommendations, not really well established within the US, like looking at CDC guidelines and everything. They basically just say if you have a family history, you should be screened. The European guidelines are actually better for this. They're always ahead of us for everything. So patients with a personal history of any kind of premature cardiovascular disease, recurrent cardiovascular disease while they're already on a statin therapy, or greater than 10-year risk should be screened with LP little a.
Okay.
Any family history of premature cardiovascular disease. So, if your dad had a heart attack when he was 40, you definitely need to be screened for this. Family history of high cholesterol, you need to be screened. And it's generally recommended that every person should be screened at one point during their life.
Okay.
Again, typically more genetic. So if you're screened once and you're good, it's not likely to make a big change.
Got it. And again, I'll kind of go back to, is this on every Cleveland we run?
Yes.
Okay, so it's not something that you're specifically ordering.
It's
on
on
top of the okay.
Yeah, because we do we do a bunch of different alpha lipoproteins within the Cleveland, so it's on every Cleveland that we run.
Okay, cool.
Yeah,
cool.
But for people who don't have access to getting a Cleveland done, this is something that's very easily ordered on any type of blood work.
Okay.
Yeah,
got it.
So treatments. You've asked about what can we do about this. Statins are kind of the standard of care for this, which doesn't make a whole lot of sense because statins can actually raise your LP little a. They're used because it lowers your LDL. So I guess the theory is if you lower the LDL, then the LP little a is not as big of a deal.
Okay.
I'm not quite sure on this one because the studies actually show that it will raise your LP little a to be on a statin. So that one doesn't make a whole lot of sense to me, but if you Google like how to take care of elevated LP little a, statins are first line therapy.
Well, there we go.
Make it make sense.
Yeah.
I don't know. So there are certain other medications. They're PCSK9 inhibitors that will lower LP little a. The most common one right now on the market is called Repatha. And this is an injection done either every other week or once a month that helps to lower cholesterol in a different way than what statins do. So statins actually block your cell's ability to produce the cholesterol. Repatha makes it to where your cells can reabsorb cholesterol better. So we're pulling excess cholesterol out of the bloodstream.
Right, and that's your big thing with statins is we do need cholesterol.
We need cholesterol. The cells need to be able to produce it. So I don't have as big of an issue with Repatha because the cells are still producing cholesterol. It's just they're able to then pull it back out of the bloodstream better. So this is a very common treatment for this. A lot of times they'll still do statin therapy first and then add Repatha on top of it. But I am seeing more and more that some cardiologists are using just Repatha now. Which makes a lot more sense because it can lower those levels.
Got it.
And so it is not actually FDA approved for this yet. we use things off label all the time. So it doesn't have the FDA approval for it, but it does work for it. It can reduce your total LDL by about 50 to 60%. No statistics that I can find on the LP(a) specifically, but it does bring it down.
Does that normally, when you're treating the LP(a), does it also impact the LDL in a positive way?
Typically.
Okay.
Yeah.
Okay.
Yeah. So niacin is another, so supplement wise, niacin can actually, and it's been shown through multiple studies to help bring down LP(a).
Okay.
It's just not been studied on a wide scale.
Got it.
Yeah,
Okay.
but that does show some definite positive benefit in lowering those levels. Interestingly enough, estrogen, so hormone replacement therapy, can lower your LP(a).
Who would have thought?
And if you remember earlier on, I said menopause can raise it.
Yep.
So women going through menopause, if you get on estrogen therapy, it actually can bring that LP(a) back down.
Interesting.
Stabilizes things.
So many positives to hormone therapy.
Absolutely.
And this is another one.
Yeah. So replacing that estrogen lowers that LP(a). We always tell people that we are helping to protect the heart with adding back in that bioidentical estrogen. And this is just another way that it's doing that.
Super cool.
Testosterone replacement therapy, same thing. TRT can help to lower that.
Okay.
Like I said, niacin can lower it by up to 23%. And there was one study where they did low dose aspirin along with high dose niacin and saw great results out of it.
Super interesting.
So there's more things on the horizon for this.
Yeah.
Even though hormone replacement therapy shows great benefit, it's not something most of your cardiologists are going to be recommending, but just keep that in mind. That can definitely be a benefit. So the only actual FDA approved treatment for this is a lipoprotein apheresis, where it's almost like dialysis, but they are circulating that cholesterol out of your system.
Interesting.
It's very in-depth. It's not something that's used very often, but that's the only actual FDA-approved treatment out there right now for this.
That is super
Everything else we're doing off-label for it.
Is this something that impacts men more than women or women more than men, or is this both?
Both.
Okay.
Yep. It's just what genetics did you inherit from mom and dad?
Man, that is wild. LP(a).
LP(a).
Wow. And this is something that's checked on the Cleveland Heart.
It is.
Okay.
But if you don't get a Cleveland, you can still get an LP(a). Get it checked at least once in your life. Yeah. If you've got an elevation, that lets us start jumping on those other risk factors early on, lifestyle modifications, all the other things that we can do to help protect the heart.
Awesome. That is honestly, I was nervous about this one because I, like most of our Explain This topics, I don't know anything about it. But you wonderfully explained that. Thank you so much. LP(a).
LP(a).
Guys, LP(a), do more research. As always, you guys name it, we explain it. And Robin, I'm still working on my outro, so we're just going to say, come see us next time.
Don't go away.